Hello everybody. I have been given the task of talking on implementation of screening for lung cancer in India state of as of now. I have no disclosures. And in the next 10 minutes or so, I'll try to discuss this under the following headings. First, why screen for lung cancer? Second, how strong is the evidence for screening? And a sub question for that is the evidence equally strong on individuals who may want to get screening? And finally, what are the challenges to implementation of LDCT screening in India? So coming first to why screen for lung cancer. So if you see, most patients present with advanced disease, which is stage 3B or 4. In fact, our own data shows that stages 1 to 2 is less than 4%, and stage 3A is just around 12 to 13%. And we all know that survival is directly proportional to stage, although that's an oversimplified statement. Whether we look at our own data, which was published a few years back, or you look at the more robust TNM data, stage, now low-dose CT screening has a tendency to detect majority of the cases in early stage, and therefore you can do curative intent treatment for this early stage disease, and the treatment of choice is surgical resection. Coming next to how strong is the evidence for lung cancer screening, and we have both published in the New England Journal of Medicine. The first one was published 10 years back. Patients were aged between 55 to 74 years. They had to be current or former smokers with a cumulative smoking history of 30 years or more, and former smokers must have quit within the last 15 years. And the number of patients enrolled was a whopping 53,000. Here the intervention was either low-dose CT screening or chest radiograph. For low-dose CT screening, any non-calcified nodule more than 4 millimeters in diameter was considered a positive scan. For an X-ray, any non-calcified, and there were 3 annual screenings performed at 0 year, 1 year, and 2 years. Now, if you look at the results, in the LDCT, both at round 1 and round 2, there were approximately 27% positivity. This fell down to around 17% by round 3, but the overall positivity rate of 24%. Now, this was significantly higher than the results with chest radiograph, which were less than 10% and overall around 7%. And therefore, it was no surprise that if you looked at the lung cancer incidence, it was much higher in the LDCT arm as compared to the chest radiograph arm with a ratio of 1.13. And as I told earlier, the proportion of patients detected in stage 1A was double with LDCT, 40% versus approximately 20% for chest radiograph. And also the overall percentage of patients which were amenable to a potentially curative treatment was also very high. And therefore, it was expected that deaths were significantly lower in the LDCT arm as compared to the chest radiograph arm. And the relative risk of death due to lung cancer was reduced by 20% with LDCT. And even all-cause mortality was reduced by approximately 7%. If you look at the other important trial, Nelson trial, now this was conducted in Europe as opposed to the NLST trial, which was in North America. This was a large-scale population-based trial involving 7 districts in Netherlands and Belgium. Again here, patients were 50 to 74 years age and should have smoked for a similar duration as for the NLST trial. And again, current or former smokers should have quit. There were 4 screening rounds here. This was at baseline, then at first end of 1 year, at the end of 3rd year, and then at the end of 5.5 years. Unlike the NLST, in the control arm, there was no chest radiograph. It was just usual care, which was basically no screening. Now, if you look at the results, the indeterminate tests were highest at round 1, around 20%, but came down to around 2% by round 4 with an overall prevalence of around 10%. And the positive test rate was around constant around 2%. Now again, the percentage of patients with stage 1A was very high with LDCT, around 47%. And for the control group, it was actually the reverse, with majority of the cancers being detected in stage 4. Also, adenocarcinoma subtype was much higher with the LDCT, which has a better prognosis as compared to the control group. And therefore, the reduced death was seen with the screening group with a rate ratio of 0.76. And here this is a diagrammatic representation of reduction in both the mortality as well as the increase in incidence picked up with the LDCT. Now we need to remember that here the target population was male participants and the power calculation was for high risk males, but it also included a small subgroup of women. Importantly, the results in women were actually better. So as you can see, for males, for both year 8, year 9, year 10, year 10, but still was better than the for males. Now, if you just compare the two trials, so NLST was MDCT versus chest radiograph, Nelson was MDCT versus no screening. Patients approximately 16,000 in Nelson versus around 53,000 in NLST. A positive result was more than 4 mm in LST by criteria. Age very similar, smoking history again very similar. But the important difference was the positivity rate. So it was 24% in LST while only 2% in Nelson. And consequently, the positive predictive value was much better for the Nelson as compared to an LST. Now, the important thing was that the proportion of stage 1 cancers was very high, 62% in LST and almost 70% in Nelson. And the reduction in lung cancer deaths was 20% in LST and much higher in Nelson. And if you looked at females, it was at even a bigger magnitude. So if you have to answer this question, it is the evidence is very strong for all individuals. The answer is no, because it's only been evaluated for heavy smokers, and we know now that there is an increasing incidence or a higher proportion of lung cancer in never smokers and light smokers. So do they really benefit equally, more or less from LDCT screening? That is something which we don't have the answers yet. Coming lastly to the challenges related to implementation. Now, one needs to remember that LDCT screening is not a test. It's a whole chain of evaluation. And if you were to compare this to a ship crossing the ocean, it's not a destination. It's a journey towards a destination. And therefore, if you want to implement LDCT, everyone needs to be on board this ship. And that will include people evaluating initially for screening, which is pulmonology, the actual process of LD screening and re-screening, which is by diagnostic radiology, tissue acquisition for abnormalities, which is by interventional radiology, tissue testing by pathology, staging if lung cancer is proven will require nuclear medicine and again pulmonology, and curative treatment if it is shown to be early stage lung cancer that will require thoracic surgeons, or if not medically operable, then radiation oncology. Luckily, at our institute, we had the immense cooperation and support of all the disciplines involved in management of thoracic tumors, and therefore we were able to do a pilot study in the recent past. And just to share briefly the results, we had assessed around 520 patients for eligibility. Finally, around 221 patients were included, which is around 43% of those screened. And we had taken age 55 to 74 years with smoking index more than 600. That was around 127 patients. And those with lesser smoking index but presence of COPD concomitantly, that was a little less than 100 patients. Now, if you look at the results, 74 patients had a positive LDCT scan, and there was a small number of patients with other abnormalities. Now, of these patients, 67 had actually a nodule, and 31 of these underwent a second LDCT. Ultimately, what came out was that we had a positive scan in approximately 34% and lung cancer detection approximately 1%, 1.4% if you took it as strictly per protocol. But if you took in all abnormalities, then this figures rose slightly higher. And this is just an illustrative of one of these cases. We picked up a smoker with a heavy smoking index of 750, 62-year-old gentleman, also having COPD, underwent screening, and as you can see, this was picked up on the LDCT, and a biopsy was done, which showed adenocarcinoma. PET scan was subsequently done, which showed mildly FPGA-avid mediastinal lymph nodes, but a staging EBUS was negative, and therefore it was labeled as stage 1A3, which is T1C N0M0. And he was able to undergo evaluation for lung dissection surgery, which is a potentially curative treatment. However, as I said, this is a chain of procedure. This is not the only barrier to implementation. The problem is also extrapolating data from high-income group countries, basically whether to take cigarettes, which are quantified as pack years, or whether you want to use smoking index, which is used for BDs or smoking products, age, age to enroll in India, the median age And finally, if you are able to find a better alternative, whether it is sputum, exhaled breath, or blood to screen, it would be preferred any day by most individuals as well as clinicians. Last but not the least is the endemicity of tuberculosis, which poses one of the biggest challenges to implementing LDCT, and it can frequently cause false positive scans. So to summarize, two large randomized trials have convincingly showed that LDCT for lung cancer screening reduces lung cancer mortality, along with smoking cessation intervention proven to reduce mortality from lung cancer. But smoking cessation has additional benefits because it leads to reduction in morbidity and mortality from several other tobacco-related non-communicable diseases, including other cancers, and therefore is a more effective and cost-effective intervention. Finally, we need to define the role of LDCT screening in never decade and a half in the field of lung cancer. Especially this LDCT pilot study was led by my department colleague and his student, and the data which has been presented has been provided by them. Thank you very much.